Welcome to the Johns Hopkins Women's Health Podcast, A Woman's Journey, Insights That Matter. I'm Kelly Gear-Ripken, and I invite you to listen to Johns Hopkins specialists discuss the latest topics in women's health. Now here's your host, Lillie Shockney.
Hi, this is Lillie Shockney from A Woman's Journey at Johns Hopkins, and this is our podcast, Insights That Matter. Today we are joined by gynecologist Dr. Wen Shen, who is an assistant professor of gynecology and obstetrics and co-director of the Women's Wellness Program. Today, we are discussing the impact of estrogen loss on your health. So welcome, Dr. Shen.
Hello. Thank you for having me.
Well, it's good to have you, and I will candidly tell all of our listeners that you also take care of me. That puts you in high ranks with me, I guarantee you. I'm very picky about who looks at me and particularly where they're looking at me.
Right.
So for the first part of this podcast, I'd like you to begin by defining what is meant when someone hears that expression, perimenopause, menopause, and postmenopause. Can you break them down for us?
Sure. So there tends to be a lot of confusion about those terms. So menopause is an all-inclusive term, right? It includes all three you just mentioned. Perimenopause usually defines the ages between 40 and 50, when most women will start experiencing irregular menstrual periods that reflect the fluctuations in their hormonal levels. And they can start experiencing menopause symptoms. I get a lot of patients who are like 41, 42 coming in and saying, I can't be in menopause. I'm too young. Yes, you're too young to be postmenopausal, but you are perimenopausal because your ovarian function is starting to go through the roller coaster stages. So that's perimenopause. Menopause and then postmenopause is defined as when a woman has gone 12 consecutive months spontaneously without a period. It doesn't count if a woman has had a hysterectomy, because then it's hard to tell if a woman is menopausal unless we do hormone levels on her. Because she's had a hysterectomy, she's not going to have a period. 12 consecutive months of spontaneous no periods. And then at that point, the woman is defined as being postmenopausal. And then for the rest of her life, she remains in postmenopause. You don't go back and forth, okay? So you remain in postmenopause, and all the changes that occur because of the lack of estrogen and progesterone will continue from there on.
Okay, let's talk a little bit now about the body changes that result as our estrogen levels diminish.
The most common, the most obvious body change that a lot of women experience would be dryness. Okay, the vaginal dryness is one of the most common symptoms that I will have a patient complain. There's also changes such as irregular menstrual periods. That's something else. During the perimenopause, a woman come in and say, I could set the clock by it all my life, and now all of a sudden it's just all over the place. That's actually the most common change that women will notice as they start the menopause process. And then there's obviously the hot flashes. Everybody's heard about the hot flashes, the night sweats. And although it is the setting for a lot of jokes that people would make about menopausal women, but it's not funny because a lot of women, when they're having these, what we call vasomotor symptoms, they can have palpitations, they have symptoms of anxiety. A lot of women go to their doctors saying, I'm having panic attacks, because that's what it feels like.
Yes.
And it's related to these dramatic changes in the body thermostat, in addition to it just being very uncomfortable and very annoying. Like right now, if I would have a hot flash, I would turn beet red and start pouring sweat. And that goes over really well if I'm giving a presentation, right? And so, I mean, that's happened to me a couple of times when I was giving lectures to medical students, and it's really, really embarrassing.
Disruptive.
And so, right. And then also with night sweats, it severely affects a woman's sleep so that she has very disturbed sleep cycles and she becomes fatigued during the day. She's irritable and her cognitive function is affected. Even though it's not a life-threatening event, it nonetheless severely impacts many women's lives and their quality of lives. Those are the most common symptoms. Other body changes that occur that are not obvious but are definitely serious medical issues include increase in cardiovascular disease, increased risk for heart attacks. More women die of heart disease than men after the age of 65. Osteoporosis. 1 in 3 women will have an osteoporotic fracture in her lifetime. As we age, when we have fragility fractures, it's not just a matter of, oh, let's just put a cast on you and 6 weeks later you're all fine. Fragility fractures don't heal well. And women then find themselves having compromised quality of life again, decreased mobility. You just don't heal right, so you can't go about your everyday business that you always did. And also, it's just a real toll on your family. That's the second thing. And then the third most serious, I mean, it affects every organ in your body, but I pick out these 3 because they can so severely affect your ability to function and your quality of life. And the third one is cognitive. Women are much more prone to Alzheimer's than men. There's a lot of research going on. Right now, what we do find is that early onset dementia does seem to be associated with estrogen deprivation. These 3 factors are very important, and they are especially important if a woman has early menopause. If she, for whatever reason, has her ovaries removed prior to the age of 40, 45, then she is at much increased risk for these issues.
I know that there are estrogen receptors on the bladder. We see the commercials on television regularly, all of the competition between different companies regarding bladder incontinence. The one thing I can say is that I think it's normalizing it, which is a good thing so that more women are going to be comfortable talking about it. But can you explain, why does this happen? I don't think many people realize that when we're looking at the bladder, it's like looking at a big muscle.
Exactly. A big muscular ball. What happens, as I said, a lot of women will complain of vaginal dryness. And what we consider the bladder, the vagina, and the vulva as the urogenital system. So the vulva, the vagina, and the bladder all have a lot of estrogen receptors on them, and they're very sensitive to estrogen. Throughout a woman's reproductive life, these 3 areas are richly supplied with estrogens to keep things really nice and thick and stretchable skin, and everything is kept comfortable, and the skin is stretchy enough to allow a baby's head to pass through, to allow intercourse. And same thing with the bladder. The bladder tends to be very tolerant, and there are times when you just don't have time, you can't find a bathroom. You can hang on to the urine, and the bladder will let you to a certain extent. However, when you become postmenopausal and the estrogen level bottoms out, the skin in the vagina and the vulva and the bladder all become extremely atrophic. And by atrophic, we mean that normally in a premenopausal woman, if we biopsy the skin in her vagina or her bladder, there will be many, many cell layers. That's a really rich, nice, thick skin. And if we were to visualize the vagina, It's nice, ruddy pink. It looks like accordion. So you can see how that skin can stretch quite comfortably. Same thing in the bladder. But postmenopausally, the skin becomes pale, sometimes white. And the skin is just so thin that I primarily use pediatric speculums in my menopause practice, just because most postmenopausal women are most comfortable with pediatric speculum.
Yes.
Because I don't want to hurt them by using a regular speculum. You can see how that skin is not going to stretch. Okay, so that's the bladder. And the bladder with just the least amount of urine in it is going to want to compress and force the urine out. And hence, a lot of women will experience urgency and frequency. That's another complaint very often. A woman has to get up multiple times at night to urinate. So between the night sweats and the multiple trips to the bathroom, she gets very little sleep. And so a little bit of just very low dose estrogen in the vagina can take care of all of these symptoms. That's one thing that I really want anybody who's listening to be aware of, because it is, as you said, something that women have traditionally been embarrassed, but just to be aware that this is a normal menopausal change that can be very easily treated with very low dose vaginal estrogen that is even now shown that it does not increase the risk of recurrence of breast cancers in breast cancer survivors. So that is a huge, huge bonus.
Yes, because we've cautioned women for decades, and it is relieving to know that there is a relatively easy fix with this. And this is in the form of a cream that comes in a tube, correct? With a tiny applicator that's smaller than a straw.
There are actually multiple forms available now. There is the cream. There's also a tiny little estrogen tablet that's smaller than my pinky nail. And there's also a vaginal ring. They all work equally well. They're all equally safe. The manner of application that you pick is up to your personal preference.
With osteoporosis, what age do you recommend that someone begin getting DEXA scans? And I guess part of this is going to depend on, have they had a hysterectomy with their ovaries and fallopian tubes out? Have they had some type of cancer treatment that would have dropped their estrogen and progesterone levels? So can you educate us about that?
The normal starting age, baseline age for a totally healthy woman without any risk factors is 65. Okay. That's the recommended age. And what the DEXA scan will do is measure the bone density and compare it against young premenopausal women. And then it will then set your risk levels as to whether you are normal or if you are at increased risk, which is osteopenia. And then if you are at much increased risk of fracture within the next 10 years, then it's osteoporosis. At that point, it's normally recommended that you seek medical treatment to help with the osteoporosis. Obviously, for women who do have medical comorbidities, it is something that on a case-by-case basis may have to be started earlier. Things that some women are not aware of is, for example, if a woman has been on Synthroid for thyroid disease, a very common condition, that can chew away at your bones. If a woman is a smoker, if a woman has certain GI issues like celiac disease or any other GI problems that does not allow normal absorption of nutrients through her gut, she's also at risk. And also women who have been on immunosuppressants, have been on steroids. These are all factors that would go into deciding when a woman should have her first bone density scan. If a woman has any of these, or if she has an early fracture, if she breaks the bone for no good reason. She hasn't been skiing, and she breaks a bone, okay? Then there should be really high suspicion that she has early osteoporosis. Or the final thing actually is a family history. If her mom had osteoporosis and had fragility fractures, all of these would go into the decision of an earlier DEXA scan. I normally will have my patients then get their baseline DEXA scan at the menopause, like around 50, 51, rather than 65, okay? Just to get an earlier benchmark of their bone density.
I know there's been some confusion with women as to when to use a vaginal lubricant versus a vaginal moisturizer. And they'll get those two things backwards. I had a breast cancer patient many years ago who was madly in love when she was in college, and their senior year they broke up and he married somebody else. She never married, she never dated again, and she moved back to Baltimore, and 40 years later, he moved back to Baltimore and had divorced, and they started dating. And she called me from Ocean City and said, he's brought me down here to spend the weekend. And I haven't had sex since I had it with him 40 years ago. And I don't even know what works and what doesn't work down there. So I bought Astroglide, and I said, okay. And she said, actually, I bought 4 of the large bottles of Astroglide. I said, you have enough lubricant for everyone in Ocean City for this weekend. So can you also talk about how much of this type of lubricant is needed or not needed? Because people don't understand that. A little bit goes a very long way. So can you talk about those two things? So the lubricant versus a moisturizer, when to use and why to use?
You have to have a sense of humor in this line of work, right?
Yes, that's right.
The vaginal moisturizer is something that a woman can use on a regular, daily, or 2 to 3 times a week basis to maintain moisture. Just like when your skin gets dry, you put moisturizers on your skin, and that makes your skin feel less dry and irritable. There are several commercial moisturizers over the counter that you can get, and they work very well in making you more comfortable on a daily basis, so that with the moisturizer, they also tend to last. They actually have ability to cling to the vaginal skin, so they continue to moisturize for the next couple of days, and it makes for more comfortable urination, because if a woman has very dry, irritable skin, the acidic urine hitting that skin is enough to,
burn. Yeah.
Right, exactly. So the moisturizers can help in that way. I have prescribed compounded, and this is about the only compounded thing that I prescribe, gel using hyaluronic acid and vitamin E. This is the same thing. It helps moisturize and coat. And then in addition, if the woman has discomfort on the vulva outside the vagina, I'll tell women to use any of the dermatologic ointments for external vulvar discomfort.
You just have to make sure it does say for external use.
Use only,
right?
Exactly, so it doesn't burn you. And then with regards to vaginal lubricants, they are to be used for lubrication during intercourse. They don't stay around. In fact, usually if you use them after the sex act is over, you stand up, they will usually come spilling out. So they're not going to do a whole lot to protect the skin, except to facilitate sex. There are a lot of over-the-counter brands that can be used. And because over-the-counter brands like that can have chemical additives in them, they'll have parabens, they may have perfumes in them that might be irritating to some patients. So in patients like that, I'll recommend just get yourself a small jar of organic coconut oil There's no additives in it. I've had patients who use olive oil. These are plant-based oils that do not have the chemical additives that can irritate.
Okay, very good, very good. Is it true that a man can go through male menopause and have hot flashes and night sweats?
The male menopause is a debated entity, depending on who you talk to. With male menopause, it's usually not the night sweats and the hot flashes. It tends to be more of a mood or sexual function related, but it's not out of the realm of possibility that they can also have hot flashes. It may also be due to whatever medications they're taking, because around the age that you would think of a man having menopause, very often they're on different medications for cholesterol, for heart, that do have hot flashes as side effects.
Mm-hmm. And men with prostate cancer are on hormone therapy, the opposite of hormone replacement therapy. They suddenly become very empathetic to their wife and will apologize over and over again for not having previously understood what a hot flash and night sweat meant. I've seen quite a bit of that among gentlemen of a certain age, shall we say.
Yes.
Oh my gosh. Do you foresee that there will be research done in the area of being able to compare, let's say, African American women to Asian women to Caucasian women in relationship to these kinds of symptoms that we all experience at some level?
I certainly hope so, because just as now it's well accepted in medicine that men and women don't react to medications the same way, and that there needs to be women's health and research done on medications on women. There should be the same with ethnic and racial differences, because there have been some data that show that Asian women traditionally, and these are Asian women from Asia, not American-raised Asians, who basically don't really complain much of hot flashes and night sweats. And their primary symptoms at menopause tend to be bone aches, arthritic type symptoms. There have been postulations that it's because of the diet and because of
soy, perhaps.
Right, exactly. The build and the activity levels of Asian women. And that there does seem to be some difference between symptoms of African Americans and white women, but not a whole lot beyond that.
Got it. So I understand that you've begun a program to coordinate care for women as they age. Can you share with us this program and how it ended up being created and what your mission is with it?
Thank you so much for bringing that up, Lillie. So it is obviously a program that is very near and dear to my heart. That's my holy grail at this point. I have worked very closely with the breast oncology group.
I'll do a little cheer for them. Yay!
Yes, exactly. Fabulous, fabulous people. And then whenever a patient comes in, I always ask them who their oncologists are, and because I know most of them, and we'll have a conversation about how wonderful they are and what their little quirks are and all that stuff. But be that as it may, I've seen a lot of high-risk women who are referred to me once they have been treated and on their way to survivorship for different cancers. And also now I have been referred patients who also have other high-risk factors, such as rheumatologic disease, even young cancer survivors from the pediatric oncology group. The very common factor among all these women is it seems like you don't just get cancer and get treated for it and you come to me for your menopause symptoms and you go merrily on with your life. The problem with a lot of the treatments that are available these days is that they cause a lot of side effects. Heart disease, osteoporosis, so many other side effects. And then patient then has to run all over Baltimore to be seen by different providers And the providers are busy, and so she maybe will get an appointment in 6 months if she's lucky, otherwise maybe even a year later. I personally have had patients who their DEXA scan showed that they had worsening bone density, and I gave them a referral for the metabolic bone group. But because of her schedule and their schedule, a year later, she comes back for her next GYN appointment with me, and she still hasn't gotten in to see them because of all these, and because a lot of patients also are just desperate. If you're not well-versed in how medicine and medical practices work, and especially in an organization as large as Hopkins, the program is designed to help improve efficiency for the patient, so that the patient can get more efficient care run by a patient navigator liaison who is familiar with all the providers who participate in our program. Right now, we have 20 different providers, and it just so happens they're all women because they're from all the different specialties, including integrated medicine, including the pain management, including physical therapy. And they have all signed on to our program, and they want to participate in giving the best possible woman-focused healthcare to our patients, because there are, quite frankly, very, very excellent clinicians whose focus are not on women. So they are not as well versed on what the subspecialty of women's care requires. These are all providers who are focused on women's health, and also this way, a woman can be sure that she is getting the right kind of advice and treatment that she needs. And we are trying to facilitate her care and develop a roadmap for her as to what she would require going forward, given her set of medical symptoms and comorbidities. We're not trying to take any other doctor's patients away. We would like to serve as a consultation service, and that way the patient can be reassured that she is getting everything at the state-of-the-art level from a Johns Hopkins provider, even if she's from out of town, even if she is in town, but at least she can have a clear picture of what it is that her care should contain. It's also because, quite honestly, and we're focusing this program on women who are 45 plus. There is excellent maternal fetal health department at Hopkins that takes care of women in the reproductive age. And so now we're doing this program. So we see ourselves as a bridge between the post-reproductive age until a woman reaches the geriatric age. And we also have an excellent geriatrics department at Bayview that's associated with the NIA. And this is a very important segment of a woman's life, because This is where she transitions into menopause. And during this menopause transition, as I mentioned before, is where she starts getting into trouble with heart disease, with Alzheimer's, with osteoporosis, with metabolic syndrome, with everything. By making sure she has the best care possible during this transition so that she can live the next phase of her life in the best possible health. Because now women in the United States are living until 85 on the average. That's a whole third of her life that she should spend without being crippled by osteoporosis, without being crippled by heart disease or dementia. So all of these issues are something that should be addressed. And then there are definitely women who have fantastic genes, right? And have no medical issues. Great. Bully for them. They don't need us. But many women do need us just to help them be able to live their best lives going forward.
Maintaining and preserving quality of life so that they're not sacrificing that as one of the elements of getting older. I'm sure that our listeners today have come to realize that hormones, estrogen, plays a very big role in a woman's health, not just her vaginal health or her childbearing health, but also in her brain, in her bones, in her bladder, in her breasts, for that matter. Right now, I've got all B's, but there's lots of others as well. I think that women are educated about this, then the sooner they can begin to proactively plan with their doctor, with you and the multidisciplinary team, so that we can head things off at the pass rather than waiting for that bone fracture, or waiting for that, gee, she really isn't remembering much of anything now, so that hopefully they can live beyond 85 and you can still see them out there running a marathon.
I do. I actually have 2 patients who are in their late 70s who run marathons, and they're very put out by the whole pandemic thing because their marathons got canceled.
Sure. They'll have to do some virtual running.
Yes.
Yeah. Thank you so much for educating us about the impact of estrogen and what role it plays with perimenopause, menopause, and postmenopause, some of the action steps that we can take, as well as understanding this new women's wellness program that you've developed, which is fantastic. And I commend you for having a patient navigator be part of that. As you know, I'm very passionate about navigation, and being able to navigate someone along this journey is really important. We don't want anybody stumbling and fumbling or waiting forever for an appointment, for that matter. Let's get them in efficiently, have them have effective consultations and treatment so that they can live their best life no matter what age they are.
My co-director for this program is Dr. Barrett Stearns, and the patient navigator that you mentioned is Kate Pisano. And really, without her, Dr. Stearns and I would be nowhere. So Kate is basically our mother superior, and she keeps everything. If a patient is interested in getting in touch with us, they can just go to Women's Wellness. We have an email, which Kate manages. Just go to Women's Wellness at jhmi.edu, and she will answer your email.
All right. Thank you so much for joining me today.
Thank you for the opportunity.
Absolutely.
All right. Bye-bye.
Bye-bye.
Thank you for listening to A Woman's Journey podcast. Join me, Kelly Gear-Ripken, and your host, Lillie Shockney, with a variety of Johns Hopkins experts on the first Thursday of each month to learn about medical advances in women's health. A Woman's Journey is grateful for the unrestricted educational grants from HRH Foundation and Keswick Wise and Wellness Center that support our podcast series, Insights That Matter. For more information about A Woman's Journey, visit our website, hopkinsmedicine.org/A Woman's Journey. Like us on Facebook and Twitter, and visit our website at hopkinsmedicine.org/A Woman's Journey. Until next time, stay well.